Thank you, Sue. Good morning, everybody. It's a real privilege to be here with you today to talk about this critically important topic. I'm just going to share my screen. While I do that, I want to say hello to everybody that's online as well as in the room. It's always a joy to speak at this conference and know that there's lots of people out there across the country and across the world. As Sue just said, I'm a member of the UK Professors in Midwifery and Maternal and Newborn Health Group, and I'm speaking on behalf of them this morning, not just myself. I'm going to be presenting a paper that we have written, and I'll give you the link so you can go and read it. And this is the title of it. It's a policy briefing called From Evidence to Action. And every single word there is carefully chosen. The safe, effective, equitable, compassionate and respectful maternity and newborn care for all. That final bit is absolutely essential. It's a human rights-based approach, missing nobody out. Just to say, there's going to be a lot of information in the slides I present today, and I'm going to move quite quickly through them. So you may want to take photos of anything that you're particularly interested in. This presentation will be recorded and available in the way that the festival always does so helpfully. And also you can read the paper that I'm going to talk about online. What's the UK network of professors in midwifery and maternal and newborn health? I can hear you asking. It's all the professors in the field, around 30 of us senior interdisciplinary academics in maternal and newborn health. Many of us are midwives by background. Some absolutely are not. They're colleagues in sociology, psychology, anthropology, other fields. The group has been developing over the last few years and now is developing a number of consensus statements on key issues. You can see there on the slide, there was a manifesto in 2024 and the policy briefing that I'm talking about today. And if you follow that link through to the Council of Deans website, the Council of Deans in Health are who we are allied with. We have a page on their website, and there you can find links through to our documents. Although this policy briefing is intended to be UK-wide and the issues are UK-wide, some of what I say today will be relevant particularly to England. And I think because of all the activity in England around the new maternity review that's just been announced, the NHS 10-year plan, you'll understand why that is so resonant. But the issues are absolutely pertinent to the whole of the UK. So this is a summary basically of what I'm going to talk about today. The context of the current safety crisis with critical gaps and blind spots. Bit of background there. I'm going to talk about the learning from the independent report in Northern Ireland that Sue just mentioned. It was the first system-wide review of maternity care in the UK. It had a particular solutions-based, collaborative and evidence-informed approach, and we'll be talking about that. I'm going to talk then about essential lessons for future maternity reviewers, including England's newly announced national maternity investigation. And then we're going to propose a radical shift in approach for what's needed in terms of improving safety for women, for babies, and indeed for partners and families, and 7 key steps to building a new approach. This is the independent report from Northern Ireland. You can find it online. I'll give you the link to it shortly, but these are some of the really positive responses to it. It's been very, very widely welcomed by the Northern Ireland Government, the Department of Health, and as you'll see here, a range of professional organisations. I'll also be drawing a little bit on a letter we had published recently, this group here of colleagues in the Lancet, where we called out one of the Lancet editorials in terms of some of the issues that are really, really important in improving safety for women and babies. So you can go and look for that if you're interested. It's very short, in contrast to the Northern Ireland report, which is very long. So you might want to have a look at both of those. This is the content of my talk today in a nutshell. If you just want to look at one slide, this is the one. The argument we're making here is that safety for women, babies, and families is worsening, whether you look at survival, physical, mental health, inequalities, short, long-term outcomes. And I'll show you some data around that in a moment. The actions taken so far have not resulted in the improvement that everybody is intending to make and that is badly needed. There are no quick fixes, but a radical shift is needed now to make the fundamental difference needed. And the new model that should be developed must be whole system, not piecemeal, informed by evidence of what works, co-designed with women, families, and interdisciplinary staff, and include both prevention and treatment across the whole continuum of care in hospital and community. So that is our thesis in a nutshell, but I'm going to unpick all of that. Starting with what is the context of the current safety crisis. I'm just going to give you a few quick graphs. So if you look at the left-hand one first, this is the most recent data from the Embrace report on stillbirths, neonatal deaths, so perinatal deaths as a whole. I want you just to look at the shape of that trajectory back to 2013. And what we see is extended perinatal deaths overall in the UK have fallen slightly, but they're more a plateau since about 2016, if you look at them back. We have seen recently a small decline in all stillbirths and antepartum stillbirths, but if you look to the bottom of this graph, where you've got intrapartum stillbirths and neonatal deaths, which are the focus of most of the safety programs, there has been no improvement. And that is a really important lesson for all of us. If you look at the right-hand graph, here we have stillbirths and neonatal deaths mapped to deprivation and ethnicity. And although we are seeing a small improvement, perhaps in Black families, we're seeing that uptick in Asian families in ethnicity, very little improvement. And if you look at the deprivation markers, what we're seeing is, again, that the women living in most deprived areas are those most at risk. The news has not improved, and in some markers has got worse. At the same time, safety for mothers has got worse. This is maternal mortality. Again, the Embrace data. This is quite complex graphs to look at quickly on a screen, but the key message is that maternal mortality is rising, and it's rising among underserved groups. So deprivation is critically important, as of course is ethnicity. And so we're seeing no improvement or worsening across those various groups, depending on which you look at. Especially in Asian women, interestingly, that's something we need to keep an eye on. Caesarean birth has not improved mortality, but it has increased morbidity and reduced women's choice. These are data from a range of sources. I don't think this will surprise anyone working in the maternity services, but briefly, the bottom blue line there is the average caesarean birth rate from OECD countries. That's those economically like us. The top lines there, that cluster of lines all going upwards, are the 4 UK countries, and indeed the Republic of Ireland, all of whom seem to be on the same trajectory, moving upwards. 2023, over 40%. And all the reports so far are saying this is still moving upwards and hasn't slowed or stopped. The green flat line there in the middle of that graph is actually the US, which interestingly used to be the benchmark for highly medicalized care. Something different is happening, and it's inevitable these rates will increase further. You will all understand the problems of repeat sections. So it's inevitable they will increase further with critically important long-term consequences for fertility, for maternal complications in subsequent pregnancies. We're already seeing that coming through. Morbidity for women has worsened. So here we've got the data on postpartum hemorrhage rates increasing. That's over 1,500 mils. These data are from Northern Ireland, but they map over to UK data. And the orange line at the top is following emergency cesarean. The turquoise line at the bottom is vaginal birth. And then in between, you've got elective cesarean and instrumental birth. So there are consequences to cesarean section and consequences to the current model of care that are incredibly important for women and for babies, and indeed for families, that need to be taken account of, at the very least, in staffing models for postnatal care. But we're not seeing signs that is happening. And the consequences for women in terms of follow-up to cesarean section are incredibly important. So the next couple of slides, we've pulled out some critical gaps and blind spots in the current approach to safety. And I'm going to go through these quite quickly. We can give you evidence on all of these. These are not just our opinion, but I'm just going to crack through them quite quickly to lay them out as if you like, the foundation for how we understand what's needed to happen next. The current approach to safety is not informed by robust evidence of what works. So there's a bit of a disconnect between the findings of what's happening in maternity care and then the solutions that are proposed, which are not informed by robust evidence of what works. The voices of women with a range of experiences are missing. It's very, very good that women who have traumatic experiences are now being listened to, but there are women with a range of other experiences that need to come to the table as well. The voices of staff with experience and knowledge are missing. There's a lack of focus on the whole system, on the socioeconomic context of care, on out-of-hospital community settings, on the whole maternity journey, pregnancy through to postpartum and indeed pre-pregnancy, on the most vulnerable, and on psychological and cultural safety as well as clinical safety. The current model of care has been developed piecemeal. Nobody developed it the way it currently has evolved. It's not strategic and it hasn't been evaluated. The recommendations arising from those important single trust reviews have not been evaluated, and there is a potential for unintended consequences and knock-on effects. The root causes and system level problems are not being addressed. There's a kind of, I'm going to come back to this later, about how we move back from describing the problems to understanding why they're there. There is, as you all know, a disproportionate focus on acute care, on the mode of birth, and on midwives that tends to obscure other key issues when people get into debate about this. There's intense and long-standing staffing issues affecting all staff. I don't need to tell anyone listening to this about that. It's affecting morale, recruitment, retention across the board. There's a lot of silo working and disconnection between sectors, between community and hospital, between social care and healthcare, between disciplines, between obstetrics and midwifery, between neonatology, between GPs and social workers and so on, and across different settings, whether those are labour ward, postnatal care, antenatal care, midwifery-led settings, not joined up. There is an adversarial and contentious public discourse, and for as long as that continues, we are not going to solve the problems. We have to be able to speak openly without fear and on a level playing field. The essential contribution of education is not acknowledged, and students do not have enough consideration, or indeed newly qualified staff. Currently, the oversight and inspection mechanisms are ineffective. They're not identifying the key problems and the things that need to be fixed. The serious short and long-term consequences that are there for women and babies and families are not being addressed. They're not even being measured in terms of the other than the immediate serious short term. But the longer term issues are not being examined. Litigation costs are higher than care costs, and anyone who doubts that, this is first of all on the left-hand side, the annual spend on maternity services, and on the right-hand side, the cost of harm from clinical negligence. Just imagine those two columns being turned the other way around, what we could achieve. And maternity care is out of line with every other specialty in terms of litigation. That long bar at the top is obstetrics, and that means all of maternity. Way disproportionate to anything else. Something very badly is wrong. It's a very difficult area that absolutely needs investment. What is the impact of these critical gaps and blind spots? What are they causing? Without doing all that analysis and catch up that I've just talked about, there is no strategic whole system plan for maternity and neonatal care with both prevention and treatment. There's a critical gap in the new 10-year plan where maternity care clearly is acknowledged as important, but the prevention, support, information, advice, the things that keep women and babies safe is missing, as well as treatment. There is no vision for what maternity and newborn services should look like. Inequalities are persisting. The blame and fear culture that has evolved is adversely affecting women and families and staff and runs through everything. There's a huge opportunity cost of the current model of care that's limiting staffing and resources for pregnancy and for postnatal care and for community. And for that, read midwifery. Not entirely midwifery, of course, but huge amounts of the antenatal and postnatal care and support, information, and community-based care is provided by midwives. And midwives cannot at the moment practice the full scope of their professional standards. They are locked into a model of care where quite a lot of what midwives know and are skilled at is limited. There are barriers to positive interprofessional debate and collaboration, I mentioned, and without that, we can't make progress. And there's unclear accountability. Who is responsible for what? And one question I will ask you here, just to illustrate that, is who is accountable for the care of women immediately following caesarean section? That's a debate over lunch. Carrying on with the impact, we have a lack of public trust. I've never known it like this. I've been a midwife for more than 45 years. I've never known such a lack of public trust. Effective interventions are not being implemented. You can talk about one-to-one care in labour. You can talk about continuity of midwifery care. Both of them would make a huge difference. Neither are being consistently implemented and funded. Appropriate interprofessional CPD that would be transformative is not being funded. Students and newly qualified staff are not being effectively supported. Women, families and staff have little input, if any, to the design, delivery and monitoring of services. There are unprecedented problems of staff well-being and morale, and staff and student recruitment and retention. Harm to women, babies and families continues. That is completely unacceptable. We need a whole new way of seeing. We need a radical shift. We need to build evidence and experience-informed whole system solutions together. And by together, I mean all of us. There is learning from what we've done in Northern Ireland. What I've just proposed is not aspirational, it's possible. It can be done. And on the way through doing this work and the follow-up to it, we have been working in exactly that way. This review was commissioned in 2023, published last year. It's titled Safe Quality Midwifery Services and Care. In fact, one of the terms of references was expanded to include the whole maternity review, whole maternity service. I'm going to focus on talking to you about what we did and why we did it, because that will then show you the way in which future work can and should happen. We had a very, very planned, systematic methodology that we developed together with dozens of colleagues from different backgrounds and with stakeholders from advocacy and user groups and service users themselves to advise how this should be done at all stages, right through these 6 interactive stages. We clarified our approach, our definitions, our methods. We worked very closely with our expert and advisory groups from Northern Ireland, the UK, and internationally. We looked at evidence reviews. We did evidence reviews. We looked at all the data, the information, the policy contacts. We went out and looked at all of that work. We had lots of engagement and participation, listening events, and working with people directly in workshops and meetings to develop the solutions, not just find out about their experiences, but to engage them in what we needed to do next. And that was a cross-section of women from different backgrounds, different deprivation, different ethnicity, different parts of Northern Ireland, different experiences, positive and negative. And we looked at positive service developments. It's always been a mystery to me about how anybody learns to do the right thing without seeing it working well. You can learn from failure, but actually to know what to do right, you have to see it and learn from it. We then did a big systematic analysis, synthesis, and developed the recommendations out of all of that. When we did a systematic analysis, we used the QMNC framework. Many of you will know the Lancet framework for quality maternal and newborn care to look at all the aspects of care that women, babies, and families need. I'm not going to go through it today because I don't have time. I know many of you will know it. It's the foundation for the NMC standards of proficiency for midwives. A lot of what's in the current safety programme you could see up in the top right-hand box, where it's very much about, if you like, medical obstetric, neonatal services. Of course, some of the other elements are in there as well, but you need absolutely to be focused on all of those elements right across the whole continuum of care and for every single woman, every single baby, without exception. So we analysed all our findings using that. We also did a root cause analysis. Now, I'm not going to talk through the slide in detail. What I want you to look at is the brown box on the right-hand side. Start there. And what we found was, some of you in the room may not be able to read this small font. People on screens will. Don't worry if you can't read it, because that's not really the point. In that brown box, you'll see very similar findings, sadly, to the other maternity reviews. Very, very difficult, serious outcomes for a lot of women. We then look back to see why that was happening. And in the pink box in the middle, you can see what the staff told us. We talked to lots of interdisciplinary staff about what was happening for them. And in there, you see some of the issues that have been identified, but we also found from staff what was going wrong. We talked with students and we listened to what was happening on a day-to-day basis for all of them. And we took that back into the grey box on the left to look at what was happening at the level of the whole health system. And that's the box where the action is most needed, is to change that. And that's about governance, it's about accountability, it's about workforce shortages, it's about silo working, it's about funding and commissioning. It's about how safety is focused in hospital and on birth and not more widely. It's about monitoring and evaluation and the culture of fear and blame. It's about CPD, and it's about disregard of the long-term impact. So it's taking away the blaming of staff, or indeed the blaming of anybody, and saying, how did the system get here? Let's work at the system level, and then the staff who want to do a good job will be able to do a good job, and that will work for women. We also looked at the positive characteristics. We looked at from what women and families told us and staff about good care, but we also looked at 15 examples of good care, and we analysed those. And these are the key characteristics of positive examples where care was going really well. These are the examples that should be out there in the media alongside the negative examples, because they were very, very important. From all of that information, we developed a set of evidence-informed key conditions for every maternity and newborn service. We very quickly put maternity and newborn together. You cannot separate women and babies at any point. We came out with this, and if you want to take any photograph of anything in this presentation, this is the one, because it's got those key conditions there, all evidenced, all derived from experience, and all agreed by the people who participated in this review. I don't have time to talk through all of them. I'm going to mention two. One at the top is meaningful participation of women, babies, families, communities, and staff. You cannot run a maternity service that works without those people actually helping to design it, as well as receiving care that's focused on their needs. And at the bottom there, we have whole system support for universal, accountable, quality midwifery. This is not special pleading for midwives. This is saying that if you're going to run a safe, quality maternity system, you have to ground it in quality midwifery. They are the only people who are there for every woman, every baby across the whole maternity journey, every family, without exception, and for both the woman and the baby. So absolutely essential, working in a completely integrated way into the interdisciplinary team with all the colleagues that midwives work with to keep women and babies safe and put them into a good start in their lives. All those other elements hugely matter. We turned that diagram around, and this really matters. We turned that diagram around to the woman's eye view. So that first one I showed you was the system view. This one now is the woman's eye view, and all those elements I just showed you are going around the outside. And for the woman, her journey is her journey that starts there in her family and community, goes through all the stages of her pregnancy, labor, birth, and postpartum, and early weeks of baby's life, back into the arms of her family and community. Critically important, women and staff all agreed that these elements here at the bottom were the fundamental characteristics of a safe and quality service. And every single one of them was called out on the way through our work. And those have to sit alongside, within and under any clinical interventions that are put in place, alongside information and support and care for women at every stage of their maternity journey. I don't expect you to be able to read this. Please don't read the small print. I want you to look at the big print. This is the programme of recommendations from Northern Ireland, where we had an integrated set of recommendations that worked together. I just want you to look around the outside. We had whole system regional strategic developments that all worked together for a consistent service working at the level of the whole system. Data and review, so everybody in the picture, including the public, know what's happening. Building for the future, capacity building, caring for our students, but also developing capacity and research and CPD education all the way through. And then finally, half of this is taken up with safe quality care and services for all in all settings, joining up all those settings, all those stages across the continuum of care. So women and babies have safe care at every single stage from every single person they encounter, regardless of their level of need and what they need together. Quickly now, lessons for maternity reviews. I am nearly finished. These are the lessons we have done our best to draw to the attention of those involved in setting up the maternity in review in England and for any other country that plans to do this. There have to be these conditions in place for those maternity reviews to get to the bottom of it, to really come out with the right answers and not move off in any particular one direction, but to listen to diverse voices, to understand the whole system, to learn from strength as well as failure, to absolutely ground it in the relevant evidence, not just from interventions, but behaviour improvement and organisational change, to use a structured analysis to identify gaps and solutions, and a collaborative implementation plan that has people engaged in that with robust evaluation, and fundamentally to keep women and families safe during the process of the review. Finally, how do we achieve this? As I said, there's no quick fixes and there's no single solution. We have identified 7 important steps. These are not the only ones. Here we are. Hear all the voices. Learn from what works. Include the whole system and the whole maternity journey. Prevention and public health as well as emergencies. Build that into the 10-year plan. Tackle the blame culture and support staff and enable the full scope of midwifery. Develop a radically different relationship with women, rights-based, starting from what women want with co-design, and monitor, evaluate and review models of care and all changes. Thank you very much for listening.